Please mute. So economic and sponsoring is important for a director of hemodialysis unit as a final step, how to reimburse the cost of the hemodiafiltration. There is no contraindication to do hemodiafiltration, but patient selection is mandatory and in the prioritizing manner to save the resources. According to the Europeans, what are the common indications for hemodiafiltration? Dialysis-related amyloidosis is important. Why dialysis-related amyloidosis? It is not the failure of beta-2 microglobulin retention. It is why beta-2 microglobulin deposits inside the joint. And beta-2 microglobulin as a native molecule is harmless. However, subsequent chemical changes with cytokines making this very aggressive for the position of intra-articular joints. And hemodiafiltration remove beta-2 microglobulin higher than in high flux, but still remove more of the cytokines are not removed by high flux. So this is the first indication that the related amyloidosis. If the patient has polyneuropathy, if has hemodynamic instability, if he has a very long dialysis vintage, more than 10 years on hemodialysis, if more than 5 years is another indication, but longer than 10 is indicated, if the patient is heart failure, diabetes, and the elderly. And if you are using the elderly, you have to my opinion, you have to use the pre-dilutional mode because for the nutritional and vascular access barrier. So this is the commonest indication for hemodiafiltration if the patient's hemodynamic instability, suffering from nutritional, dialysis-related amyloidosis, not beta-2 microglobulin retention, polyneuropathy, very long dialysis vintage, diabetes with heart failure are also importantly to think about hemodiafiltration. The basic for performing effective, you need a high flux, more than 1.8, ultra pure endotoxin filtration, approved hemodialysis machines. You need blood flow about 350 with the dialysate 500, convection volume from the start above 17 by the Turkish study. Nowadays, it's more than 23, at least by the ISOL studies and Spanish studies. So the dialyzer need to define the ultrafiltration, should be higher than 40 at least. The surface area, I prefer 1.8 and bigger, resistant to elevated transmembrane pressure by more of the membrane characteristics. The machine should have a feedback control, can do back flush the membrane pores, what's called back filtration on demand, maintain membrane permeability. Blood flow, blood viscosity, transmembrane pressure, dialyzer characteristics. So one of the cornerstone is to select the dialyzer. To my opinion, narrow lumen dialyzer is not good in hemodiafiltration. So the internal diameter is important because it confirms smooth blood flow. There is two categories of the blood internal diameter in fibers. We have 185, which is the smallest internal diameter, and this is not suitable for hemodiafiltration because of the shear stress and very high pressure drop. Clotting is high, and another internal fiber with higher than or equal to 100 micron internal diameter, and is very suitable for hemodiafiltration. You have to check this point. Second point, you have to check the sieving coefficient. If you have a sieving coefficient, for example, myoglobin, like 0.1, hemodiafiltration will not solve the problem. You need at least a sieving coefficient of 0.5 myoglobin to remove sufficient cytokines and others. If you are using a membrane with a low sieving coefficient, hemodiafiltration is innocent. Why it doesn't improve the patient well-being? This is one of the important issues I highlight here the vascular axis. If you are using low blood flow, there is clotting, higher TMP, ultrafiltration failure. And if you are using a hemodynamic filtration machine, you have to check that it can do pre and post, and it can have a feedback control. Bigger surface area dialyzer and hemodiafiltration we are using in Hisham University in our clinical trial. We are using the largest surface area inside not only national, but in the international market. We are using the 2.6 square meters in different clinical research, and this improving the patient well-being too much, especially that the bigger surface area here in this category has a very high as well saving coefficient of myoglobin 0.7. So we tackle that by bigger surface area and saving. One important issue, larger surface area dialyzer meaning higher ultrafiltration and meaning lower transmembrane pressure. So smaller or lower ultrafiltration meaning that higher transmembrane pressure, and the reverse is correctly perfect. This is a DOS study, the blood flow. This is during the hemodialysis session, almost of the between 250 and 400, but again, in hemodiafiltration, we need more. This is a clinical study saying that if you are using the native arteriovenous fistula, you can reach the target of the substitution, but while you are, if you are using a catheter, for example, the percent of achievement of the huge substitution volume is only a third of patients. So what you can do for a patient with a catheter, cath, and you need to do hemodiafiltration, simply we extend the time. If you are not reaching the goal, we extend for 1 hour, for example, 5 hours dialysis. Finally, you can reach the substitution volume of around 23 liters if the vascular axis is not well. The filtration fraction is another information we should know, meaning that the percent of the ultrafiltration on the either the blood or the plasma flow. Take it in consideration is the blood flow. For example, if you are using an ultrafiltration rate of 100 and a blood flow of about 300 milli per minute, so the filtration fraction is 33. In the all scenarios, substitution or filtration fraction above 30% is risk for the dialysis surface. So usually filtration fraction above 20% and less than 30%. In order to have such a filtration fraction, you have to increase the blood flow. Subsequently, you can increase the ultrafiltration. You cannot increase the ultrafiltration rate while you are using a very low blood flow. So filtration fraction is important item. We have to prescribe that and write that in the hemodiafiltration sheet, the filtration fraction of each of the session. This is from Urodial, and you can see that the blood flow corresponding to the ultrafiltration rate in the safe way between 20 and 30% in the post-dilution. While in pre-dilutional, the more easy. Increasing the blood flow, you can increase the substitution flow with lower filtration fraction, and the key point here is the arteriovenous fistula flow. These are different studies. I understand that Dr. Tarek Tantawy will cover, but in general, if you look to this important one, substitution to the body surface area, around 52 per week liter. So if you have a very small patient, for example, 40 kilograms or 50 kilograms, you can reach the substitution lower than 23, but in the range of around 52 per square meter surface area per week. So this is a dose per week. If you decide to do hemodiafiltration, we have to do thrice weekly hemodiafiltration, not once weekly hemodiafiltration. So filtration fraction is important, and it depends on the UF on the QP. If you are increasing the filtration fraction, the filtration will stop due to very high protein content and hematocrit. And so the key is to increase the blood flow in that. And this is the final, the hemodialyzer surface area. Ceding coefficient should be very high. Using the vascular access is better. If you need to go with very high blood flow, you need special needed for 14 or 15 gauge. And the post dilution is around 23 liters in post dilution, and the pre-dilution is around 50. Automated part of the hemodialysis machine is important, and you can find here in my last slide, the manual mode, you can find very high transmembrane pressure, but if you're using the automatic mode, the machine can control by feedback control, and once the transmembrane pressure exceeding 300 millimeter per mercury, stop the ultrafiltration and do on-demand back filtration or intra-circle injection of saline. I wish that this talk is highlighting the technique of hemodiafiltration, looking for very high TMV and the high hematocrit, and we are all know that high hemodiafiltration dose is related to survival, while low hemodiafiltration dose is not related to survival and nothing benefit like exactly high flux dialysis. And thank you very much.
Thank you, Professor Tarek, for your elegant presentation. And now we shall go directly to Professor Dr. Tarek Tantawy to start his talk, and discussion will be opened after the second talk. Professor Tarek?
Yes, sir.
Are you ready?
Yes, I have to share a screen first, yes?
Yes.
We have to stop sharing from Professor Hisham's side first.
Dr. Hisham, stop sharing, please. Professor Hisham, Dr. Hisham, stop sharing. Yes.
Okay.
It's free now.
Okay. Many thanks, Professor Muntasir Zaid, for your kind introduction. Really is a hard task to speak after Professor Hisham Said, the godfather of dialysis in Egypt and Africa. But I would like to add something about the clinical benefits of hemodiafiltration. Despite continuous improvement in hemodialysis devices, membrane biocompatibility, and dialysate purification, mortality among end-stage and these patients remains unacceptably high. High flux membrane were introduced many years ago to increase the clearance of middle large molecules. The anticipated advantages of high flux dialysis over low flux dialysis were not confirmed in HEMO study. Subsequently, the result of MAPO study showed that high flux dialysis is associated with better survival in patients with hypoalbuminemia and diabetes mellitus. European-based practice guideline suggested that the use of high flux membranes should be considered to delay the long-term complications of dialysis, like dialysis-related amyloidosis, hyperphosphatemia, cardiovascular disease, and anemia. High volume online HDF marks a new step toward native kidney blood purification. High volume online HDF offer more effective uremic substance removal over a wider range of molecular sizes than other dialysis modalities, which has been associated with potential clinical advantages. The DOPS study showed mortality risk reduction of around 35% in patients treated with high efficiency HDF compared with than those treated with low flux or high flux dialysis. The dialysis strategies, as mentioned by Professor Hisham Said, hemodialysis, where the diffusion is the principal way for solute removal and the transport through a semi membrane, and the driving force is the concentration gradient on both sides of the membrane. As regards hemofiltration, where the convections is the main principles for solute removal, and the driving force is the transmembrane pressure. Hemodiafiltration is a combination of both diffusion and the convection. We have different modalities, as mentioned by Professor Hisham Said, of HDF are defined by the route of substitution fluid, either post-dilutional, pre-dilutional, or mixed dilutional, and mid-dilutional HDF. The issue of uremic toxins, we have uremic toxins in different ways, either small water soluble or protein bound compounds like advanced glycation end products, homocysteine, bicresol, phenylacetic acid. On the other hand, the small water soluble water soluble uremic toxins are divided either smaller, where the molecular weight is less than 500 Dalton, or middle and large molecule, where the molecular weight over or equal 500 Dalton. Clearance data in hemodialysis versus HDF, as you see, there is no differences with the small solute uremic toxins, but on the other hand, where there is more bigger of the uremic toxins, molecular weights, there is no way for low flux, but here will be a need for high flux or HDF. Removal of protein-bound solute bicresol by HDF is a randomized crossover study. As you see, there is a high prevalence and the preference of removal of protein-bound uremic toxins by HDF nodules. Is the beta-2 microglobulin plasma level reduction of clinical importance for improving patient morbidity and mortality? This data extrapolated from Lombardi registry and presented by Locatelli, dialysis membrane and the risk of carpal tunnel syndrome. The relative risk for carpal tunnel syndrome increased in case of hemodialysis versus HDF or high flux dialysis and of statistical significance. Alfred Cheng published serum beta-2 microglobulin levels predict mortality in dialysis patient. This is where the results of the HEMO study. The figure showed the relative risk for mortality increased with the pre-dialysis beta-2 microglobulin. So, is HDF able to improve survival? The diagram showed that the mortality risk is reduced in patients receiving hemodiafiltration versus hemodialysis, and this accounted by 35% reduction. Hemodialysis should lead to efficient removal of enhanced small, middle, and large protein-bound uremic solute clearance, better intradialytic hemodynamic instability, reduce the inflammatory marker, improve the phosphate control, increase the erythropoietin responsiveness, better beta-2 microglobulin removal, and lower risk for carpal tunnel syndrome. For that, there is better survival with HDF. This is the middle molecules and the protein-bound substance that is removed via HDF, beta-2 microglobulin, advanced glycation end products, bicresol sulfate, homocysteine, leptin, and erythropoiesis inhibitors. The figure showed that serum phosphate in hemodialysis and HDF, there is high privilege of phosphate removal in hemodiafiltration versus hemodialysis and of statistical significance. Intradialytic systolic hypotension in hemodialysis, hemofiltration, and HDF, there is increased percentage of intradialytic hypotension in hemodialysis patient, where reduction of intradialytic systolic hypotension and hemofiltration, with more reduction of intradialytic systolic hypotension, intradialytic hypotension and HDF module. Also, EPO dose after 9 months of online HDF reduced with the mode of HDF. Also, switch to online HDF increases the serum albumin concentration. Also, there is effect of HDF on nutritional status by removal of leptin in comparison to low flux hemodialysis or even high flux dialysis. There is influence of online HDF on pro-inflammatory cytokines. This is figure showed randomized controlled trials in Europe evaluating HDF versus hemodialysis. The Dutch trial, where there is 715 patients enrolled. This is a contrast study. They are comparing low flux hemodialysis versus HDF, and the Italian group, the convent study that compared low flux hemodialysis versus high flux and the HDF. Number of hemodialysis patients 17, 14 in HDF, and 36 in hemofiltration. And the French trial, where they compare high flux hemodialysis versus HDF, and there is around 410 patients in the study. And the Catalonian trial showed they compare high flux hemodialysis versus HDF, and around 900 patients were in the study. And the last one is a Turkish study. They compare high flux hemodialysis versus HDF, and there is around 800 patients enrolled in that study. The figure showed patient survival were better in HDF versus hemofiltration versus hemodialysis. 36 months survival in the intention to treat population. Also, the survival probability were best and better on online HDF versus hemodialysis and of significant statistical significance. On the other hand, all-cause mortality was not affected by the treatment. They're comparing low flux hemodialysis versus online HDF, and this is the survival curve time to this from any cause based on life table analysis using 3 months time period. This study was published by Groteman. Another study by Oki et al. About the cumulative survival on patient on online HDF versus high flux hemodialysis, and a composite event free survival in patient treated with online HDF and high flux hemodialysis. As you see in the curve, there is better survival in patient on under online HDF. This is meta-analysis of randomized control study about comparing convection versus diffusive dialysis. About all-cause mortality, there is a reduction around 13% in patient receiving convection therapy versus diffusion therapy. Another meta-analysis of randomized controlled trials comparing mortality in patient treated with hemodialysis or hemodiafiltration, there is a reduction of about 16% of mortality in patients who received HDF versus hemodialysis. Meta-analysis of all randomized controlled trial comparing cardiovascular mortality in patients who receive hemodialysis versus hemodiafiltration. Also, there is a reduction of cardiovascular mortality about 27% in patients who receive hemodiafiltration. Locatelli present that 5 studies and comparing HDF versus hemodialysis as regard all-cause mortality and the cardiovascular mortality. The 5 studies, 4 of them showing reduced cardiovascular mortality in HDF versus hemodialysis, where all-cause mortality, there is no difference in 3 studies versus 2 only, they recommend where there is reduced mortality in HDF. New insight into the effect of hemodiafiltration on mortality, the Romanian experience by Dimitri Soroborili. They studied the effect of HDF on mortality in incidence patient. A patient in HDF group maintained a reduced risk factor for all-cause mortality with hazard ratio around 0.20, and when with unvariate and HR is 0.24 for the fully adjusted model. The figure showed the effect of HDF on mortality, and the Romanian study in this patient. There is significant cumulative better survival in patients who received the HDF versus patient in hemodialysis. The effect of HDF on mortality in the Romanian study in prevalent patient, also the patient who received the HDF, there is better survival than patient who received the received the hemodialysis in the Romanian study. And the figure showed the effect of HDF on mortality in the prevalent patient. There is better survival. The cumulative survival in patients with under HDF is better than hemodialysis. The RIM registry, they comparing HDF versus hemodialysis and survival. Hazard ratio for all-cause mortality and the cardiovascular mortality is better in patients who received HDF versus patients who received hemodialysis. What about elderly? The treatment tolerance and the patient reported outcome favor online HDF compared to high flux hemodialysis in the elderly. The Kaplan-Meier curve for 24 months survival intention to treat, there is better probability of survival in patients who receive HDF versus patients who receive hemodialysis. Hemodiafiltration reduce all the cause of cardiovascular mortality in incidence hemodialysis patient, a probability matched cohort study by Madwell, and the Kaplan-Meier analysis comparing cardiovascular mortality between HDF and high flux hemodialysis. There is better survival in patients who receive HDF. So, hemodialysis or hemodiafiltration, that is the question. This paper was published by Locatelli. He do a meta-analysis of observational studies about comparing HDF versus hemodialysis. Most of the studies refer there is better survival in patients undergoing HDF versus hemodialysis, and also randomize the study on HDF as regard survival. Also, there is better outcome in patients who receive the HDF. Locatelli had published that meta-analysis that comparing hemodialysis versus HDF as regard some clinical issue as regard the phosphate, as regard the anemia, as regard the vascular mortality and all-cause mortality. Actually, the results are conflicting with sometimes better for hemodialysis and sometimes better for HDF. Are the highest convection volumes in HDF mandatory for improving patient survival? The figure showed HDF by replacement fluid across Europe, where HDF with high convection replacement fluid are taking the upper hand. What I mean that more than 20 liters per sessions per hour. Pros with this hypothesis. Risk for all-cause mortality by achieved convection volume. This study by Grotenman, where he compared total mortality among the patients who received HDF versus hemodialysis, with increasing the convection volumes tertiles, there is better survival in comparison to hemodialysis. The panel on the left side showing overall mortality, and the panel on the right side showed cardiovascular mortality with better survival in patients who received high convections HDF. Here, they recommend use of more than 70 liters per session versus other replacement fluid versus high flux hemodialysis. Association between this is the convected volumes, survival, and replacement fluid. With more replacement fluid, convection fluids, there is the hazard ratio for mortality is less. HDF replacement fluid volume and mortality. With more fluid convection fluids, there is less mortality and better survival. This study published by Davenport about the higher convection volume exchange with online HDF is associated with survival advantages for dialysis patients. The effect of adjustment for the body size. They tested in prospective trials over 3 years duration different methods to standardize online HDF convections volume on all causes and cardiovascular mortality compared with hemodialysis. Convection volumes were either not standardized or standardized to weight, body mass index, body surface area, and the total body water. Data were analyzed by multivariable Cox proportional hazards modeling from 2,793 patients. All-cause mortality were reduced when the convective dose was unstandardized or standardized to body surface area and the total body water. Higher convection volumes were generally associated with greater survival benefits with online HDF. The figure showed that the hazard ratio and the survival were in favor with the usage of online HDF versus hemodialysis. Also, hazard ratio for all-cause mortality and cause-specific mortality by delivered body surface area standardized convection volume in liters per 1.73 square meter per treatment with standard hemodialysis as the reference. As you see, with more convection replacement fluid, there is better survival, either adjusted or unadjusted. The figure showed the convection volumes per session needed for an individual participant to have at least body surface area adjusted the convection volume of more than 23 liters or above based on the measurement of height and weight of the participant. Cano represent published optimal convection volumes for improving patient outcomes in international incident dialysis cohort treated with online hemodiafiltration. As you see in the figure, with more replacement convection volumes, there is better survival for patient undergoing HDF. Cons of that hypothesis. Risk of all-cause mortality in HDF by achieved convection volume is a meta-analysis using univariate meta-regression analysis found no effect of achieved convection volumes on all-cause mortality. This study published by Nestor. The baseline median convective volume was 22 liters per session, higher than that achieved with contrast study, but lower than that from Ishol study. And in their analysis, it was not associated with mortality risk. And they conclude there is, in contrast with the finding from the 3 randomized controlled trials, where in all post-hoc analysis, an association between higher convection volumes and the better survival. Locatelli published mortality risk in patients on HDF versus hemodialysis, a real-world comparison from the DOPS study. They studied the association of HDF with mortality in the real-world clinical setting, studying a contemporary DOPS cohort in countries where HDF is available. Adjusted number of patients around 2,000. The adjusted Cox regression was used to estimate the association between HDF and the mortality, all-cause cardiovascular and the infection-related mortality. Also examined whether the facility practice of treating more patients with HDF was associated with survival. The figure showed that the association between HDF versus hemodialysis and the all-cause mortality by the level of adjustment, there is prevalence and better survival in patients who receive hemodialysis versus patients who receive HDF. Also, HDF and the cause-specific mortality, either cardiovascular mortality or infection mortality. Also, there is better result with hemodialysis versus HDF with whatever the replacement fluids. Also, does the survival advantages of hemodifiltration depend upon the delivered convection volumes? The figure also showed that there is the rate of risk for the convection volume no matter as regard the better survival. So what is more important, the convective volume or the infusion flow rate? The convective dose not only depend on the overall convective volume achieved, but also on the infusion flow rate. Madwell et al. Found that conversion from 5-4 hours thrice weekly online HDF to 7-8 hours every other day with online HDF showed different patterns of solute removal, which were related to the dialysis time, convective volume, and or infusion flow rate. Patient with dialysis time 4 hours and infusion flow rate 100 ml per minute obtained a similar convective volume as those with dialysis time 8 hours and infusion flow rate 50 ml per minute. So the figure showed that with more infusion flow rate and more dialysis hour, there is better survival and better and less mortality. And also there is better clearance of uremic solutes with the higher time, higher replacement fluid, and the higher infusion flow rate. This is the recommendation to have an optimal hemodialysis dose, vascular access, either fistula or graft or caster. First, we have to increase the blood flow as much as we can. And also, we have to increase the dialysis duration. QB, as I mentioned before, around 350 up to 500 maximum is possible. Dialysate flow 400 to 500 ml per minute plus infusion flow rate, as I mentioned, but no influences on convection dose. So there is no need to increase dialysate flow. Infusion flow rate 25 to 37% of the QB maximum is possible. Dialysis duration 4 to 5 hours per session, maximum possible. Convective volume, replacement volume, the intradialytic loss, more than 23 liters per session, maximum possible. Percentage effective convective volume of the blood processed 25 to 30%, maximum possible. Dialyzer, high flux membrane with ultrafiltration coefficient more than 40 ml per hour per millimeter mercury with SC for beta 2 microglobulin, more 0.66. Avoid membrane with high adsorption capacity ultrafiltration coefficient. In conclusion, several randomized controlled trials support the superiority of online HDF compared with the standard hemodialysis, especially when high convection volume, more than 23 liters, and the infusion flow rate are delivered. The analysis of many HDF practices do not support the notion that HDF is superior treatment in comparison to hemodialysis, even focusing in HDF with the highest convection volumes. Further trials specifically designed for testing the effect of different convection volumes of HDF versus hemodialysis on clinical outcome are necessary. And at the end, very thanks for your attention.
Thank you, Professor Tarek, for your elegant presentation. Actually, we enjoyed two talks from our Professor Hisham Said and Professor Tarek, and I will summarize some of the points I get from their talks. Success and the benefit of online HDF depends on availability of special requirements. Actually, it needs experienced nephrologist and the nurse. High quality water treatment is essential. Dialysis machine is specifically designed for online fluid preparation. High flux dialyzer, more than 1.8 square meter surface. And also Professor Hisham highlighted the giant dialyzer of 2.6 square meter surface, and we are waiting the results of its use in HDF. Actually, the largest surface area I used is 2.2, and till now I was afraid to use 2.6 surface area the dialyzer. But with the study, ongoing study of Professor Hisham Said, I was encouraged to be for this surface area to be used. Actually, HDF needs a good vascular access with a blood flow rate in excess of 350 milli per minute, which could be attained by a native arteriovenous fistula or arteriovenous graft. And if you are using a dialysis catheter, then if it will not provide this amount of blood flow rate, you will need to increase time to be able to achieve the same result as 350 milli. In fact, investing in these requirements would not only improve quality of life of dialysis patients, but it will reduce the rates of morbidity and mortality. Professor Tarek elegantly presented that substitution fluid should be more than 23 per liter per session. It is essential if you are looking for the survival benefit of patients on HDF. A point I want to stress is the anticoagulation for HDF. Actually, we used sometimes in conventional dialysis, we may use low molecular weight heparin, which I think is not appropriate for the situation in high flux in HDF, as it will be lost through the dialyzer with the HDF, as it is of low molecular weight, and it is mandatory to use unfractionated heparin in this modality. Actually, also unfractionated heparin, a part of it will be lost in dialyzer. Also, I think, at least at first, the bolus dose of heparin, which will be given as a start of HDF treatment, should be given in the venous line. And then after that, you can infused through the arterial line to prevent clotting of the dialyzer, especially if you are using the post-dilutional mode. These are some of the points I want to stress in this very interesting session about HDF. And now subject is open for discussion.
Let me catch if you speak, Professor Muntasir, and start by one question from the chat. What's the cost difference between hemodialysis and HDF? This is in consequence of your speech about that it deserves its cost and the cost difference. What's the cost difference between HD and HDF approximately? Can we have a...
We can estimate that there will be a difference in cost about 1,000 Egyptian pound between both. If you assume that the conventional hemodialysis session costs about 500 Egyptian pound, HDF session can cost up to 1,000 or even more Egyptian pound. The high cost of this HDF comes from the back filters which are present on the back of the machine. Each filter cost, we need 2 filters on the back of the machine to yield what we call cold sterilization of the ultra pure dialysate. To obtain this ultra pure dialysate, which is endotoxin free and bacteriologically, of course, to be free, we need 2 filters. Each one costs about 4,000 Egyptian pound and should be replaced every 100 sessions, or at least 3 months duration. We have to change these back filters to obtain an ultra pure dialysate which can be infused intravenously. So the high cost of this modality of treatment comes from the cost of the machine itself, which is more expensive, even double price that of the conventional machine, and also from the cost of the back filters. In addition to that, we have the cost of the high flux dialyzer. Of course, the high flux dialyzer, there is a difference in price between low flux dialyzers and the high flux dialyzer. So we can expect that the cost of hemodiafiltration session is higher than that of the conventional dialysis session. But actually, if you are looking for the survival benefit of our patients, which exceeds 35%, according to the studies mentioned by Professor Tarek, then we can say that yes, it is costly, but also we can gain a benefit. Also, we have to know that the cost of phosphate binders, especially the non-calcium based phosphate binders, will be reduced by HDF because a large amount of phosphate will be lost during HDF treatment. Even I can go to that BTH will be reduced as a result of hemodiafiltration because the molecular weight of BTH can pass through the high flux dialyzer during hemodiafiltration. So there will be an improvement in the overall state of metabolic bone disease, and also there will be reduction in the cost of medications used to reduce phosphate level. Second point, you will also notice by using HDF that there will be a reduction in EPO dose used to correct anemia in our chronic kidney disease patients. As a result, in improvement of inhibiting factors which inhibit action of erythropoietin. There will be better correction of anemia, and also at the same time, there will be reduction in the dose of EPO and also the cost. Third point, if you put in consideration hospitalization rate. Also, there will be reduction in rate of hospitalization in our dialysis patients as a result of introduction of HDF. As a result, the rate of hypotensive episodes during dialysis is reduced. Also, the cardiovascular complications which can occur during a hemodialysis session will be reduced with the use of HDF. These are some of the benefits you can gain from in comparison to conventional hemodialysis, and it may ameliorate the cost or the higher cost of HDF in comparison to conventional hemodialysis.
Professor Hisham Said.
Can you please first let me allow to be online by my video, please? You shut down my video.
Okay.
Yes, here I can feel it again. Thank you very much, and thank you, Professor Montasser. I have some remarks on that talk, and for your question, according to the international, not the national way, the cost is around 10 euros excess. How much is that? Yes, it's around, the difference is around 10 euros. By
10
different,
euros?
Yes, from 10 to 15 euros, depending on the country.
Actually, Professor Hisham used to deal with European people, and the cost of conventional dialysis in Europe, in insurance companies in Europe, is about hemodialysis conventional unit.
I am talking about the cost, not the price.
Yes,
Professor Montas, I am talking about the cost, not the price.
I will go to that. For a hemodiafiltration session, it costs 190 euro. So there will be a difference of about 20 to 25 euros in Europe between the conventional dialysis session and the HDF session. In Egypt, there will be a larger difference. Maybe this is due to additional cost of the companies dealing with this.
Let me just to explain that the major cost of the equipment and what is it called? This is the basic of the installment of dialysis machine. But the running cost is different from machine to machine. For example, you can have a 2 endotoxin filter, very cheap for some kinds of hemodiafiltration, and very expensive on the other. And on the same time, you can buy the same endotoxin filter from the global purchasing system in Egypt, very, very cheaper than you can go directly by yourself. Additional way that in general, the hemodiafiltration cost, not profit, is marginal depending on the blood tubing system and the hemodiafiltration endotoxin line, endotoxin filters. But if you are going up and using the 3-barrier system, which means that 2 endotoxin filter and 1 disposable extra filter, the cost will go higher. In all, as perfectly mentioned by Professor Dr. Montasser, cost-effective way. So if you have a patient selection, you need malnourished, anemic, residual uremic syndrome, intradiabetic hypotension, different alarms during the session, interruption of the session, inadequate dialysis, and mortality. So this is, you cannot standardize hemodiafiltration as basic therapy in any units, anywhere, but you have to do a basic selection. To my clinical experiences and from literatures, it's around 25% of the whole population on dialysis unit is achieving hemodiafiltration. I think not less, not higher than this value. Some countries like Switzerland are going to 80% and higher hemodiafiltration. Some like Germany are doing around 30%. Some others like in Gulf centers are doing nearly 100% in some units. So the variability between decision is not well scientific. If you are using the main resources to do hemodiafiltration, you have to make patient selection way. And I mentioned that in my talk, you have to do the best for malnourished, anemic, low appetite patients, residual uremic syndrome, dialysis-related amyloidosis, heart failure, intradiabetic hypotension, and this is for sure, this is a first priority for hemodiafiltration requirements.
Actually, I want to stress the importance of using HDF in patients with multiple myeloma. Actually, we are missing the medium cutoff membranes, and in HDF for these patients will lead to clearance of light chain from blood circulation. And I think this category of patient can get benefit from HDF if they are indicated for dialysis.
Yeah, sure. For the kappa light chain, if you have a kappa lambda ratio, for the kappa light chain is 24,000, and higher for lambda it's around 45. So if you are using hemodiafiltration, you remove much of the light chains. But we have to stress on 2 points. Nowadays, light chain is considered as a uremic toxin, not only as a myeloma. So it's one of the inflammatory markers, even if the patient has no myeloma. Second thing, if you are doing hemodiafiltration to mimic or to be in the medium cutoff range, you have to stress on the sieving coefficient of the filter. So I agree partially that hemodiafiltration could support the patient with myeloma or acute kidney injury with light chain disease, but we have to stress on the membrane type when using that in hemodiafiltration with an optimum sieving coefficient values.
Professor Saeed Khamis wants to comment. Repeat, please, Professor Saeed.
Thank you, professors. Thanks, Professor Hisham, Professor Tarek, Professor Muntasser. One question for Professor Hisham and Professor Muntasser, Professor Tarek, this regarding the hemodiafiltration indications. Can we add to the indications, I mean, roughly this post-dialysis, and the other one is intradialytic hypertension rather than second question to Professor Hisham, what is the difference in the absorptive capacity between hemodiafiltration and the high flux conventional dialysis? Thank you so much.
So I can start by my answer by the second question. What is the difference between absorption capacity? Yes, there is two dialyzers which have a very high absorption capacity, which is the polymethyl methacryl, or what's called PMMA membrane. Professor Tarek highlighted that. The PMMA is vanished and not suitable for even high flux dialysis because absorption is very high. Second one is the AN69 or acrylonitrile, and one of them is now optimized for CRRT right now and very, very expensive without, I think, to my opinion, it's still the absorption capacity. Basically, the membrane for filtration is not suitable for absorption, and the membrane suitable for absorption you can reduce for filtration. And this is my thought that the main problem with hemodiafiltration is the absorption of proteins. So we have to use more hydrophilic, more porous, less absorption of protein. So this is a convincing way that I can treat the patient. And the second point, if you are using membrane for absorption, you should not use it as a hollow fibers. You have to use absorption like a plate. So if you are using a membrane and promoting that for its absorption capacity, you have two very big scientific words. Number one, its absorption will fail the filtration. Number two, hollow fibers will not be suitable for absorption because of shearing stress. Because shear stress inside the lumen of the fiber will shedding out the absorbed proteins. And so if you're using absorption, you have to use like plates. For your question, I didn't hear it well. Your first question.
Regarding extra or plus indication plus regarding the hemodiafiltration. This post-dialysis fatigue and the intradialytic hypertension rather than hypotension. Do you have an idea about this? Because I searched in the literature, I couldn't find something conclusive to this.
Yes. For post-dialysis fatigue, we are actually enjoying your talk in the Congress of the post-dialysis fatigue, partially improving, yes, post-dialysis fatigue, because you have a replacement without that. But you can have a higher post-dialysis fatigue if you are increasing the net ultrafiltration volume. So if the patient has 5 or 6 kilograms and you are doing hemodiafiltration, the net ultrafiltration is very high still. And if you are using very high sodium in dialysate, you can have as well a post-dialysis fatigue. So traditionally, if you improve the dialysis parameters for ultrafiltration dialysate composition between high flux and hemodiafiltration, yes, you can have some improvement in post-dialysis fatigue. And this is not for research. This is from our clinical experiences with patients. Second point, which is intradialytic hypertension. No, because it removes much more of the dialyzable drugs. And again, nothing to do with intradialytic hypertension, but improve the cardiac stability in intradialytic hypertension, especially if you are using dialysate with temperature of 36 during the session.
Okay,
we have many questions. We have many questions on the chat. Professors, starting from Dr. Brahim Sayed, thank you for small molecular weight solute clearance. Which is more effective, convection or diffusion? So, if use very low dialysate flow in some machines, can hemofiltration be better than hemodialysis? And can we depend on hemofiltration instead of hemodialysis as a measure of clearance in case of low dialysate flow?
Hemofiltration, no dialysate. Actually, in hemofiltration, no dialysate. In HF, we have a dialysate. But as you see from the table, increasing the dialysate flow has no matter to increase the clearance. As regard the question about comparing dialysate flow in low flux versus high flux versus hemofiltration.
For the clearance value of small solids, yes, it's a little bit higher in hemodiafiltration, but it's very marginal because the equation of clearance depending on the pre and post value and the difference multiplied by the QP. If you put a convection, the calculation adding plus QOF on the pre and post values. So QOF increasing the clearance value, but just for few digits. So it is not a big issue to say that it's higher for high convection therapy in the small solids. But in larger solids, the story is very different.
From Dr. Muhammad Abdel Bari to HDF clear interleukin 6. Do you have any experience in treating cytokine storm in patients with COVID, even with normal renal function?
Yes, it can remove interleukin 6, but, and this is very important, it depends on the interleukin 6 amplifiers. So if you have a patient with interleukin 6, like example 10, and no production, it will drop down by hemodiafiltration to 2. But again, in COVID, the problem is not only the removal, is the production rate. So if you exceed the production rate, you have a reduction ratio. If you don't exceed the production rate, you will not achieve such a figure. In our studies, it's very variable in between patients, depending on the interleukin 6 genes. So to your question, does hemodiafiltration remove in the interleukin 6? Yes. Does it beneficial for patients with COVID? Yes, but with prolonged time to compensate for the production rate.
Actually, I can add to this, Dr. Muhammad, that we did a study for COVID patients. We did plasmapheresis for these patients. In a small study, about 10 patients, there was a significant reduction in interleukin-6 through plasmapheresis for these patients. But actually, in our study, there will be again the survival benefit because our patients were subjected to plasmapheresis after failure of medications to reduce this interleukin-6. But actually, there will be significant reduction before and after a plasmapheresis session in level of interleukin-6. But actually, these patients were put on plasmapheresis very late. And so the outcome of this study was not that good as regards survival, in spite of significant reduction in level of interleukin-6.
There is a philosophical question from Dr. Ibrahim Al-Awad asking about if HDF will replace current hemodialysis in the future.
Yeah, it will.
I hope so. I hope so.
Okay. From Dr. Dua Adil, any instructions about protein intake during hemodiafiltration?
Yes, we encourage high protein intake. Look, I will add some points to, if you allowed me to add to Professor Dr. Muntasser. Sometimes we find a paradox. You know that the hemodiafiltration marginally remove more phosphorus. The time factor is more important than the flux in phosphorus removal. But paradoxically, patients with hemodiafiltration, it's too much because you remove cytokines, you remove leptins, you remove a lot of the suppressing to the appetite to the patient and eat much. So if your patient on hemodiafiltration, you suspect the nutrition is better and you have to replace the albumin loss is around 3 grams per session if you are using in post-dialysis mode, but still you have to restrict the phosphate intake and you have to be aware about the beverages, blah, 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 all of the kinds of phosphate because we can find a paradox of increasing phosphate.
I can add to this point that actually, yes, there is an albumin loss during HDF, but at the same time, there will be loss of albumin-bound uranic toxins. So there will be some gained benefit of this small amount of albumin loss during an hemodiafiltration session, which can be, yes, and you can correct this. Maybe if you need to give an albumin infusion, or you can increase protein intake to counteract this drawback of some loss of albumin during a session.
If the serum albumin is borderline, I prefer to start with pre-dilutional mode.
Yes.
So this is very minimal albumin loss, and you gain the effective way of hemodiafiltration.
Yes, you elegantly presented this point and highlighted this point during your talk, Professor Hisham.
Dr. Ibrahim Said has a question that I cannot get clearly. Please unmute yourself and explain your question. Dr. Ibrahim? Dr. Ibrahim, you are unmuted. Dr. Ibrahim, please explain your question.
We can move to the other question.
Yes, we can move to another question. A minute, please. Any difference in the outcome to start early or late HDF in critical cases in ICU?
Dr. Tarek, I think you highlight that for in the studies that even in the incident dialysis patient, you may start hemodiafiltration.
Yes.
So in critical cases in ICU, if hemodynamics is stable, you can, if available, hemodiafiltration system inside the ICU, you can do hemodiafiltration. If not available, you can go to SLED. And if your patient is very critically ill, you can go to CRRT. So you have to choose. Yes, you can do hemodiafiltration, but logistically, it's difficult to have an inline hemodiafiltration inside ICU, except if you have not a portable dialysis water, but if you have a huge system of dialysis supply, water treatment.
We can do HDF in the ICU by CRRT machine with the same principle.
Yes,
and dialysis.
Yes, of course, we can use continuous venous hemodiafiltration in intensive care units.
Yes, this is using tags, not in line. Yes.
Yes, it will be continuous with bag solutions. But if the intensive care unit is equipped and connected to water treatment system, which I have implemented in some of the dialysis units and the intensive care units under my supervision, I connected these units to a hemodialysis, to water treatment system of the dialysis unit, the big dialysis unit in hospital, and to help to apply SLED for these patients inside the intensive care unit. And if the online dialysis machine, we can transport to intensive care unit to do online hemodiafiltration. But for every intensive care unit.
But yeah, it's usually to do inside the ICU using the CRRT or a SLED machine. I'm really happy that
for the high cost of the CRRT machines and solutions, to reduce these costs, I connected some of the intensive care units in big hospitals with the water treatment system and of the water treatment system in the unit, in the dialysis unit. And so we can use conventional dialysis, SLED, or even we can transport the online HDF machine to the intensive care unit to do online HDF session for 4 hours. But actually, if the patient is critically ill, we can utilize the Prisma Flex or the multi-filtered machines inside intensive care units.
Okay, I'm really happy that the audience is trying to get your experience, professors, and they're asking about all what are in their minds. Some questions like, what are the causes of exudative ascites in dialysis patients? What are non-dialyzable antihypertensives? What are dialyzable antihypertensives? But I think this is unfortunately behind our scope today, and we are somewhat late, and we can early address these topics later on in later lectures. Thank you for your share, all audiences in these questions, by your questions. We have no more questions on the chat, and I have one question. You said, for Professor Hisham, you said that HDF can be used in patients with uncontrolled on hemodialysis regarding beta 2, for example, microglobulin. How long should elapse till we till we judge that it is uncontrolled and need to shift to HDF?
Yes, it's a good question. There is no sufficient data. If you shift a patient with dialysis-related amyloidosis with already deposit in the joints, it will be very hard to be removed. But if the patient develops dialysis-related amyloidosis, you can have a preventive strategy from breaking down the joints and the other deposition of beta-2 microglobulin. As I highlighted, beta-2 microglobulin molecule is not alone is the cause of dialysis amyloidosis. It should be chemically modified by cytokines. So if you shift the patient for that hemodiafiltration, there is no time frame to stop. You have to continue hemodiafiltration for a protective way. Meaning that, and we have in the studies and in our as well in our hospital, the pre-dialysis beta-2 microglobulin, for example, between low flux and high flux, is a differ around 20-25% alone. So the value of removal of beta-2 microglobulin alone is not sufficient. And that's why if your patient has a dialysis-related amyloidosis in some joints, in like carpal tunnel syndrome or entrapment syndromes, you have to continue hemodiafiltration for life.
Okay, Dr. Ibrahim Said joined now. Please explain your question. Again, you are unmuted, please, and you raised your hand. Okay, thank you for addressing. Thank you for addressing the point of diabetes mellitus with heart failure, Professor Hisham. They are really difficult to manage these patients, and HDF could represent one solution to for these patients, how to manage and how to go on safely and effectively on hemodialysis for this patient, and difficult to deal with diabetes mellitus with heart failure.
Yes, I think hemodiafiltration is a first choice for those patients for cardio protection, because those patients have an autonomic neuropathy, has a polyneuropathy, more vulnerable for complications, and many of the uranic toxins are retained. So many of the inflammation like diabetic food, cytokines production. So routinely, hemodiafiltration in those patients may improve the survival. Not like what happened in the membrane permeability outcome using high flux in diabetic and low serum albumin. I add here over that membrane permeability outcome studies, those patients are, to my opinion, one of the biggest column of the indication for hemodiafiltration.
Okay, thank you. We have no more questions on the chat, and we have no more comments. Professor Muntasir, I think it's time to close.
Yes.
It is nearly 2 hours, more than you said in the start, Professor Hisham, more and more.
Yes, the discussion with friends is very fruitful, and really we enjoyed that. And we can spend all the night, but I am afraid that you have to return back to your home, or are you in clinic, and staying in the evening. Wishing you all a very good night.
Thank you. I won't sleep. Thank you.
Actually, it was a very educational and very interactive and very delivering a very important message to all of us. Many thanks to Professor Yasser for this elegant night. Thank you, Professor Hisham. Thank you, Professor Tarek. And thank you for all audience. Professor Saeed, thank you. Thank you, Dr. Abdelbari, and all our colleagues. Thank you for this interaction and the interactive session.
Thank you, Professor Muntasir, for your excellent moderation for this session. Thank you, Professor Hisham, for your highly elegant talk, as usual, informative and educational. Thank you, Professor Tarek, for your very nice lecture. We enjoyed it too much. And thank you for all audiences for their share. Again, I am really happy with their share and questions and being with us today. And I am to announce that the next Wednesday will be, inshallah, Professor Muhammad Salah ad-Din, acid-base balance, next Wednesday, 9 p.m. Excuse me to close this fruitful session. And thank you all. تصبحوا على خير. شكرا جزيلا.
شكرا جزيلا.
Bye bye.
Bye.